Greetings to everyone. I welcome you all to this International Surgical Lecture Series webinar, which is an educational combined initiative between the Association of Surgeons of India, Chennai City Chapter, and Apollo Hospitals, Greams Lane in Chennai. The idea of holding these series of webinars is to bring very well-known surgeons of international repute in the field of GI surgery, laparoscopic surgery, and robotic surgery to share their knowledge and wisdom to not just the practicing surgeons, but also the postgraduates. In the past, we have had some eminent surgeons come for this webinar and share their knowledge. We've had a couple of well-known surgeons from the UK. We've had a surgeon from Italy. We've had a surgeon from Australia, and this time we have had the honor. We are having the honor of having a surgeon from a country which is much closer than all of these, and that's Malaysia. So we have with us Dr. Vimal Vasudevan. I will be giving a formal introduction about him a bit later, but before I pass the stage to some of the dignitaries who have logged in, I just want to give you a bit of some ground rules. After the initial speeches by some of the dignitaries who have logged in, and after the introduction of the speaker, Dr. Vimal Vasudevan, will be giving a lecture on the topic minimal access surgery, past, present, and future. So the lecture is going to be for about 30 minutes, after which we're going to have question and answer session. So as Dr. Vimal is talking, if you have anything to ask him, please type in the chat box and I'll try and collate them and relay it to him. And we'll try and take as many questions as possible in the discussion section. The one thing that I want to say about this webinar, which is slightly different to the other 4 webinars. This is the 5th webinar that we are doing in this series. But I have to say this one is slightly different to the previous 4 webinars because of the simple fact that the topic that we have chosen is a very generic topic. The earlier webinars were on specialty-specific topics like surgery at the esophageal hiatus, management of Crohn's disease, intracutaneous fistulas, robotic surgery, D3, right hemicolectomy. So very, very specialty specific and fairly hi-fi topics. But today we are going to have a topic which will be of interest to almost every surgeon who has an interest in minimal access surgery. And to be honest, this day and age, there is no reason why a surgeon should not be having an interest in minimal access surgery. If you are a surgeon, you need to be knowing and you need to be doing minimal access surgery because that is going to be the future. We have transitioned from laparoscopy now to robotics. And so minimal access surgery is here to stay. And it's extremely important that all of us know enough about this to sustain a good, safe, and a sound practice. So the topic is a very general topic. And I'm hoping that this will be of interest to a lot of junior surgeons who will be logging in shortly. It will be beneficial to many postgraduates as much as it is going to be for some of us who are extremely keen and eager to hear from Dr. Vimal Vasudevan. So with that little bit of an introduction, I want to invite the chairman of the Association of Surgeons of India, Chennai City Chapter, Dr. Kannan, who's a laparoscopic surgeon, surgical gastroenterologist practicing in a private hospital called Prime Indian Hospital in Chennai, to say a few words. Dr. Kannan, please.
Very good evening to all. Warm welcome, and on behalf of the Association of Surgeons of India, Chennai City Branch, I once again welcome you all for this International Surgical Lecture Series. It's under able guidance of Professor B.K. Reddy sir. Dr. J.K. Jameel has initiated this program. there is no doubt this is a program that enlightening the knowledge to among all our surgeons, including PGs, practicing surgeons, postgraduates, and as well as all the senior surgeons. It's a platform for sharing our knowledge and as well as experience. Today, we are having the speaker. He is having vast experience in minimal accessory, more than 2 decades. Dr. Vimal Vasudevan. Almost he is globally known everyone. That's why we are having global presence from UK, Malaysia, and as well as our past president Satish Mehta sir has joined today. So like that, this itself indicates the importance of the topic and as well as the personality what we are having today as a speaker. And sir is the founder president of Endoscopic, Laparoscopic, and Robotic Surgeons of Malaysia, and as well as he is the founder president of Malaysian Hernia Society. So because of his passion in the minimal access surgery and as well as the administrative activities and the entrepreneurship and as well as the relationship with all the surgeons all over the world, he has initiated all these programs in Malaysia itself. And recently also in Calcutta meeting, we have met each other. So with this, once again, I welcome you all for this today's lecture. It is very common to all, and as well as he is going to share his experience, how was in laparoscopic, how was in endoscopy, how currently the emerging and as well as enlightening and most fastly growing robotic surgery in minimal accessory. So for which, with this, I like to all of you please listen his talk and as well as whichever queries, whichever your thoughts you can put in our message box. After this talk, let us have the vision of his experience. Over to Dr. Jameel. Thank you.
Thank you, Kannan. Thank you for that. May I now invite Professor Dr. Prasanna Kumar Reddy to say a few words. Just an introduction about Prasanna Kumar Reddy. I don't think I'll be doing justice if I have to introduce about him in just a few seconds or a minute, particularly when we are in a webinar talking about minimal access surgery. What shall I say? He is one of the senior most laparoscopic surgeons of the country. Apollo Hospital, Chennai, Apollo Hospital, Greams Road, Chennai, which is, we passionately call it as Apollo main hospitals in Chennai, is 43 years old. And he's been there more or less since its inception. He's one of the pillars of Apollo Hospitals, Greams Road in Chennai. He brought in laparoscopic surgery to Apollo Hospitals and has trained numerous surgeons in the field of laparoscopic surgery over the last 3 decades or so. He also started the surgical gastroenterology department in Apollo Hospitals. And you will be pleased to know at this point in time, we have 6 DNB surgical gastroenterology postgraduates. And we have had a great number of FNB minimal access surgery postgraduates as well over the last many years. So you can imagine how many candidates have gone through the training system, which was pioneered by Dr. Prasanna Kumar Reddy from Apollo Hospitals and are now doing extremely well in different parts of the country. I mean, as I said, I can go on and on, but I will stop here. And I think many of you already know him. And we were just having an informal chat before we started this webinar. And I was quite pleased to hear that Dr. Vimal himself, Vimal, who's our guest speaker today, himself has had some training courses hosted by Dr. Prasanna Kumar Reddy many years ago. So it's actually a very nice and a pleasant experience to have Dr. Vimal back here and giving a talk in a webinar in the presence of Dr. Prasanna Kumar Reddy. And he's a patron for the entire program. He's been extremely supportive of this initiative. We look forward to hearing from Sir. Sir, please.
Thank you very much, Jameel. Those are nice words, Jameel. But I always remember first when I wanted you to start the robotic surgery. That was the one which is the one that makes me happy even today.
Thank you, sir. Thank you, sir. That's another thing. Absolutely.
Yeah. Good evening, respected colleagues. distinguished faculty, and dear friends. It gives me immense pleasure to welcome you all to this session of the International Surgical Lecture Series organized by the Chennai City branch of the Association of Surgeons of India by Professor Dr. Kannan in collaboration with Apollo Main Hospital, Greams Road, organized by Dr. J.K. Jameel of Surgical Gastroenterology Department. At the outset, I extend my warm greetings to our esteemed speaker, Dr. Vimal. It was really a pleasure talking with him. I saw him long time ago. And to our moderator, Dr. J.K. Jameel, for his nice, kind words, along with all the office bearers and participants who have joined us today. The theme of today's lecture, minimal access surgery, as Professor Kannan said, is a very interesting one. It's a past, present, and future is both timely and relevant. Over the last few decades, we have witnessed remarkable transformation in surgical practice. I remember one word, our beloved chairman of Apollo Hospital, he forced me to start laparoscopic surgery because I was very comfortable in doing open surgery after returning back from UK. And he forced me and saying that, well, the world is looking at laparoscopic surgery, should start immediately, he said, actually. That's how I started in 1992. And so from conventional open procedures to laparoscopic and now the robotic techniques. It's very interesting, the robotics, how they emerged. And these advances have not only improved surgical precision, but have significantly enhanced patient outcomes, reduced hospital stay, and improved recovery. As surgeons, we have had the privilege of being part of this evolution. However, with rapid technological growth comes a responsibility to continuously update our knowledge and refine our skills and critically evaluate new innovations before adopting them into practice. Platforms like this lecture series plays a crucial role in bridging the knowledge gaps and fostering academic exchange. They allow us to learn from international experts like Professor Vimal and share experiences and reflect on how best to integrate these advancements into our own clinical settings. I'm confident that today's session will provide valuable insights into the journey of minimal access surgery and offer a glimpse into what the future holds, be it advanced robotics and artificial intelligence integration or further refinements in techniques. I encourage all participants to actively engage, ask questions, and make the most of this academic opportunity. Before I conclude, I would like to appreciate the efforts of the organizing team for putting together this excellent program and ensuring the smooth execution. Thank you all for your participation. I wish this session a great success. Thank you. Thanks, Jameel.
Thank you. Thank you, sir. Thank you very much. May I now have the pleasure of formally introducing our guest speaker. Our guest speaker today is Dr. Vimal K. Vasudevan, MBBS, MS, FMAS, who's a Malaysian general surgeon with over 2 decades of experience in minimal access surgery. He currently practices at Gleneagles Hospital, Penang, and previously served for many years in the Ministry of Health at Hospital Taiping, where he helped pioneer laparoscopic surgery in the region. Dr. Vimal is currently the president of the Society of Endoscopic and Laparoscopic Surgery of Malaysia, which I believe is now rechristened as Endoscopic and Laparoscopic and Robotic Surgery of Malaysia. So it was earlier called SELSMAR, and I just heard from Dr. Vimal before this meeting that it is now rechristened as SELSMAR with an R at the end. He He's played an important role in advancing minimal access surgery, surgical education, and regional collaboration across the Asia Pacific. He's a regular invited faculty and speaker at major international conferences, and that is how I got to know him. We have met a few times in various conferences in India, and I know he's going to visit us again in Guwahati in the ARIS conference in a few weeks' time. Dr. Vimal's academic interests include abdominal wall reconstruction, minimal access surgery, robotic surgery, and surgical education. He remains committed to mentoring young surgeons and promoting safe, evidence-based surgical practices while fostering international collaboration in surgery. Dr. Vimal, it's a pleasure and honor for us to have you in our program today. And we are keen to listen to your lecture on the topic minimal access surgery, past, present, and future. Please go ahead.
Thank you, Dr. Jameel. First of all, it's a great honor for me to be invited to speak on this webinar, especially among very senior colleagues. Dr. P.K. Reddy, thank you very much. You I think, were my examiner for my fellowship exams in minimal access surgery. So that's how back I've seen you. I see a lot of you as my mentors. So thank you very much. So for the next half an hour to 45 minutes, I will talk to you about the evolution of minimally invasive surgery. Can I share my slides, please? Okay. Can you all see?
Yes, sir.
Yes, we can.
Okay. So, greetings. This is my hospital, Gleneagles in Penang. It's a very small island in the northern part of Malaysia. I've been in the private practice since 2009. So, currently I hold the position of a director of a weight loss clinic in the Gleneagles Hospital. And I'm also the president of the Asia Pacific Hernia Society currently for the next 2 years. As Dr. Jameel said, I'm also president of the Malaysian Society, Endoscopic Robotic Surgeons. And I've left my post as the founder president of Malaysian Hernia Society to somebody younger. So currently hold the role of advisor to the Malaysian Hernia Society, and also on the advisory board and chairman of a Congress committee for Endoscopic Society of Asia. All right. So many great people have said, to look at the future, you must first look to the past, because the past teaches you, So we should not go into too much detail about all this, but suffice to know that it is not my words alone. It's very great people have said it. Okay. To me, my inspiration. So the picture is actually of my medical college in Hubli, Karnataka. When I was studying there, it was known as KMC, Karnataka Medical College, government hospital. And the one on the left is Professor Vijay Kant, who was my surgery boss, professor of surgery, my unit. He was my inspiration, great man, great surgeon, very humble, drives around in his Vespa. But whenever he takes clinics, the room overcrowds with students from other units also will spill in. I'm sure most of you will have that experience too with great professors. Everybody wants to listen. They made surgery look like poetry in motion. And the one on the right is my mentor when I returned to Malaysia to work in the northern part of Malaysia, Mr. R.R. Naidu. Also great surgeon, great. He very inspiring to all of us. Okay, so this is my past. These two gentlemen actually motivated me to do surgery because they did surgery in that era. If you look back, many of you will know these incisions and scars are very familiar to a lot of us. Probably not so much these days, So my surgeon used to come into the theater. If you're struggling with a small incision, he will get upset. He said, the bigger the surgeon, the bigger the incision, the better the surgeon. So this was the dictum then, So you better not struggle with a small incision. However, these big incisions came with a lot of morbidities, pain, scarring, loss of productivity. Patients cannot go back to work, complications of the wound, complications lung-related, prolonged hospital stay, So all this was the cost to pay for getting better. But this is what they knew, and their training came from people like this, Joseph Lister, William Halsted, Bill Roth, John Hunter. They were the pioneers. But for hundreds of years, more than 100, over 150 years, surgery was practiced in this way. If you look back in ancient times in India, Shushruta also, credited to being the first surgeon. Okay, with his own surgical tools, he was doing surgery open way. Okay, so for many years it was expected as the gospel truth. If there was a sacred book and on surgery, it must be open. Okay. Now, somewhere in the early 1900s, that was the Industrial Revolution, technological era. So Robert Kelling founded the laparoscope on a dog. So then as you go through time, here and there, years apart, you get people doing something, but not actually establishing a revolution in minimally invasive surgery. Okay, you got Varis needle somewhere in 1938, and it's only when optics became better in 1960 by Hopkins, then we realized we can actually see, but the lights were very hot, so they need to come, cold lights were there before, and then insufflator, SEM, he introduced carbon dioxide insufflator. So for once, you can create a space in the abdomen and introduce light and look into the Pandora's box, But it's only in 1985, the first recorded, even though there have been multiple instances before that. Muhe did the cholecystectomy. So what happened to Muhe? So these are the guys, great surgeons who went against the convention of 150 or 200 years or a millennium, if you look at it, to go against the flow and say, hey, there is another way of doing, So the first laparoscopic cholecystectomy was done in 1985, okay, by Eric Muhe. All right, he's a German surgeon, but he had to give up because he landed in a lot of legal trouble, in threats of incarceration, deregistered. Okay, and Philippe Mouret did it in 1987 in France. So this has been acknowledged by Murray's family itself, and then the German society exonerated him. Imagine doing a procedure which we take for granted now, and that point in time, people had to go to prison or under the threat of being deregistered or going to prison itself. Okay, so this is how far it has come. All this will tell a story and a lesson. Now, why laparoscopic surgery or minimally invasive surgery? So I did this presentation during my presentation oration, Tempton Woodwardia's Professor Tempton Woodwardia's oration in Calcutta. So what are the benefits of laparoscopy that makes us...
Good evening, everyone.
So I'll let him tell you that.
I wanted to take a moment to share something important with all of you. The poorest of the poor have as much right as anyone to less pain after surgery, reduced medication, less morbidity, shorter hospitalization, and early return to home, family, and work. Minimal access surgery and the expensive technology it requires is advocated, not as homage or tribute to new technology, but in appreciation of the manifold benefits this new technology gives our patient and our people. Also, before I go, my greatest joy is to see my residents perform far bigger and better surgery than I could ever do.
So those are the words of the great man who is credited to being the father of laparoscopic surgery in India, I believe. So due to that benefit, all the post-op benefit, quick recovery, less pain, less use of pain analgesia, faster return to work, reduced loss of productivity. So this became a good and interesting venue to explore. So started probably after gallbladder became a gold standard, and the imaging systems and the energy devices became better. Hernia started exploring both in groin and ventral hernia. Colorectal surgery started off with benign. There was some restriction of doing it for malignant diseases, which were later dispelled. Okay, for upper GI also same. Initially started for benign disease because of the good short-term benefits. Okay, but with caution for malignant diseases as well. And the hepatobiliary pancreatic surgeons were quick to take it up. Endocrine surgeons, for their adrenals, retroperitoneal adrenalectomy, their thyroidectomy, those have undergone. So bariatric surgeons, not to be outdone, started. So because of minimally invasive surgery and the benefits it gives to the patient, bariatric surgery exploded back onto the world. I remember as a medical student or a trainee in surgery, the chapters on weight loss or bariatric surgery were the ones we didn't have to study because nobody will ask. We have never seen it, never done it, But with the advent of laparoscopic surgery and the benefits which came with it, bariatric surgery really exploded onto its own, So much of progress. And then abdominal wall reconstruction over the years. Many things have taken shape. Okay. Now, I told you there was some resistance to use of laparoscopic surgery in malignancies of the GI tract. Now, these are very groundbreaking studies. I'm sure many of the seniors or maybe all trainees should know about this classic trial and the Color 2 trial and the Korean trial, which showed beyond doubt that minimally invasive colorectal surgery was a possibility. It gives you good short-term outcome without compromising on oncological safety. Okay. And it's comparable to open surgery in terms of oncological safety and gives short-term benefit. So all this comes of benefit to a patient. Patients know they have to go for surgery, but they also want to recover quickly and go back to their function. Paying for cost of surgery is not easy. So they have to go back to work and start earning as soon as possible. So minimally invasive surgery allows them to do that. Okay, so this is how we have come across, and after that there was no stopping anybody. It was expected. So over the years since then, combination of human beings who are highly skilled and technology becomes the instrument for change. So if you didn't embrace laparoscopy, then you look like the odd one out. In the initial years, it was not so. I think many of us, when we were starting off on laparoscopic surgery, we had a lot of resistance, especially from very senior clinicians. I'm sure some of you will remember everything which went on in the West also happened in Asia. At least it happened to me. Everybody is on your case, telling you not to do this, don't waste your time, too expensive. But a lot of surgeries have become gold standard, minimally invasive surgeries. So you can basically do from head to toe. Okay, except of course you can't deliver babies, which are actually a form of a natural orifice procedure as well. So changing of gold standards happen. You are not comparing gallbladder with open surgery anymore. If you do robotic surgery now, you have to compare to laparoscopic surgery. You can't compare robotic gallbladder surgery with open gallbladder surgery anymore. It doesn't work that way. Similarly, for hernia also, especially ventral, you don't compare robotic hernia surgery with open hernia surgery. No more. That's why there is a struggle in many parts of the world to introduce robotic surgery from a monetary point of view as well as the legal point of view. Now, it's not only the Western countries which had giants. Okay, Asia had its giants too. And these were the role models and mentors, various parts of Asia, whom we looked to when we were starting to grow in the era of laparoscopic surgery. And Dr. P.K. Reddy is one such giant. I'm sure I'm missing out many, okay, and I'm sorry for that. Now, if you look at the evolution of inguinal hernia surgery, okay, prior to it has been around since in the 1800s. Okay, all tissue-based repair. We have seen hundreds of variations of Bessini's repair. Everybody will add on their modification, and it was all tissue-based repair until 1958, where meshes were introduced. And then became popular, and the Liechtenstein procedure 1984, not too many years ago, where mesh became a commonplace and a standard of care for hernia surgery. Of course, a good tension-free repair, suture, tissue repair is still good, and shoulders being the one commonly proposed by many guidelines. Okay, now somewhere in the 90s, because of laparoscopic instruments being available and hernia being the most common disease condition, there was a lot of absorption of laparoscopy. So there was initial years where there was a big debate going on. Every conference you attend is between TAPP and TEP. Then many guidelines and systematic reviews showed that there's not much difference between the two in terms of clinical outcome. So slowly that debate has died. And then along the way you have the E-TAPs for groin coming about, many variations of that also. And since the 2010, you get robotics also coming into the hernia. So it's what? Robots coming into the area of inguinal hernia, but it is so easy to do it laparoscopically. Why do we need robots? But then ask yourself, this is what those people who are our detractors said to us when we are going into minimally invasive laparoscopic surgery. It's a simple surgery. Why you want to complicate by doing it by laparoscopy, So this is, we have to be careful not to blame the next generation. Now, is the robot the next generation or is it a present? This is the question. If you look at the ventral hernia also, you see from 75 to now, many surgeries, it was all open, and then you have your IPOM and it's a variation where you close the defect, then the E-TAP, tape, so many. And then it ends recently, all of them with robotics as well. So what is this new kid on the block? Somewhere in the 2010s, it started coming up. So I will now talk about robots and maybe we have to decide whether this is present or is this future. Okay, now Da Vinci was initially brought about, okay, in the 80s, 90s to treat battlefield soldiers, soldiers hurt in the battlefield because clinicians were not able to go to the battle zone. So they created these robots to do surgery on the soldiers, fallen soldiers. Okay, then the surgeon picked up this concept and thought that, hey, this could be commercially used in our patients as well. It has the same benefit, So the first Da Vinci came about, and then after that, subsequent generation, they kept on improving on it. Okay, now we have the DV5. So the problem with the robots was it was only one company making it for many, many years, and they monopolized the market. So the cost was expensive, mostly done by urologists only. Because if you go to many countries, the insurance only covers for the urologist. Somehow they managed to convince that only their surgery is complex and difficult to do. Okay, so they have gone without most of them, I think. They have gone from open to straight robotic. They have not bypassed with laparoscopic surgery like us. Okay, now we have many companies, many companies, and see, so the idea is, as there are more and more companies coming around the world, you will get cheaper or financially better models of robots in the market, and this will become an explosion. So this is what is predicted. Okay, if you look at so initially it was all North America, okay, and Europe leading the way for many, many years. Currently, Asia Pacific is growing faster than the rest of the world. Okay, and the area of discipline which is fastest growing is general surgery. It's not urology, it's not gynae. They are there, but the fastest growing is general surgery. That's why you get a lot of companies coming up to you. And if you look 10 years before, maybe they will just ignore surgeons. Okay, and the average yearly growth rate also is about 16% for any business. If you look at it from a business point of view, is very, very, very good. But most of it was in places like China and Japan. Okay, these were the growing markets. Of course, in recent times, you have to put India in the group as well. Now, if you look at this article, Indian Trade Administration, this is an article produced in the US. So you see, it's growing. It is one of the quickest growing. I'm talking about robotics field because it's driven by government initiative. So you will have to thank the government for it. Also, population which is growing, and the population which can afford better. Okay, and now they are the fourth largest, fastest growing surgical robotic market in the Asia Pacific region. Okay, so the money being told is too much, 4 billion. This is what is expected in India by 2031, just another 5 years away. So who wouldn't want to be part of it? Almost every hospital will want to be having a piece of the pie. Okay, so India is currently the fourth largest and fastest growing market. It's the fourth largest, but it's the fastest growing market in the Asia Pacific region. Okay, and from my research, I found out there have been 12,000 cases done as of 2022. I'm very sure in the last 4 years, it would have doubled or even tripled. If, I will need my other fellow faculties from India to confirm that for me. And apparently, currently, there are about 850 robotic trained surgeons and 160 robotic installations. So comparatively, in Malaysia, we have 26 robot installation. Okay, but not many. Actually, there are less robotic trained surgeons than there are robotic installations. You figure it out. So I have one robot all to myself. I don't have to worry about another surgeon using it. Only I have to worry about the urologist using it. Okay, so what makes the robot so appealing? Is it just market forces? Of course, the view is this is a paper by Ferdinand Coquelin. Uh, it it says that in terms of visualization, you get 3D definition view, and with excellent depth perception. 3D gives you excellent depth perception. Of course, in laparoscopic surgery also there is 3D, but it is not the same. When you do it on a robot, it's simply mind blowing. Okay, and dexterity is much more. You get 7 degrees of freedom. And then if you compare images, video of a laparoscopic surgery and a robotic surgery, same surgery side by side, you will find the robotic platform very stable, movements, nothing, no shaking, tremors, because all that is filtered. If you look at laparoscopic one, you'll find a lot of tremors and movement by the cameraman, by the surgeon. So makes me wonder how in the era of laparoscopic surgery, we were going to conferences and watching videos, and our body just filtered out, our mind filtered out the tremors, I think. Surgeon can sit down and do. So it reduces fatigue and strain on the patient. So it's very important for a laparoscopic surgeon. If you are going to stand and do many long surgeries, I think when you reach a certain point in physicality become limited, such as aging, okay, then you're going to back off doing many advanced procedures. So this is actually of no benefit to the patient because you are so experienced, your decision making is top notch, but you're physically limited from doing certain surgeries. So robots can remove that physical limitation, you see. So it's a good thing, and the other things, precision and control. So why is all this benefits not told by anybody? If you look at most of the systematic reviews and whatnot, most of them say the outcome is no different. So you see all these benefits, but it is not seen in terms of outcome. It's just a surgeon's feel, you know. So all these benefits are not seen as a clinical outcome. So this is the disadvantage we are having in promoting it to the powers that be. Some countries, the government doesn't allow because they look at reviews saying that the outcome is same. So they tell you, okay, just do laparoscopy, we don't want robot. In many countries, insurances don't cover for robotic surgery, only for urology surgery, okay? So, and the learning curve also, the initial part is steep because you're sitting on a robot platform, you have to learn how to use the robot. Laparoscopy is shorter, okay? Operating time is longer because you have to set it up, you have to dock it, undock it, you have to probably scrub in and scrub out 1 or 2 times. So all this, But when you look at blood loss, it's lower in complex cases. So this is where the robot comes onto its own when you're doing complex cases, complex GI cases, and if you compare to laparoscopic surgery, definitely much more benefit in colorectal, hepatobiliary, pancreatic, gastric, esophageal, okay? So blood loss is less. And if you look at conversion also, is lower if you're doing complex cases. Post-op recovery is comparable. You see, oncologic safety, comparable. Cost is definitely more, okay? And accessibility is an issue for now, okay? Maybe not in the future when they become cheaper, okay? So they are very suitable for complex, deep-seated procedures. That's where the robot comes into its own. But you can't go and do only complex cases. You need to learn how to use the robot. And the most common surgeries are ones you get to do more often than not. Okay. And the robot doesn't have haptic feedback, the feeling of touching something. This is the same thing they told us when we did laparoscopic surgery. You don't feel it. but we learn to feel. And having done robotic surgery, I am not sure. I want to confer to my seniors on this, but I feel like a muscle memory. Maybe it's my laparoscopic surgery muscle memory. I feel like a haptic feedback when I'm doing something. It's maybe a bit like your phantom limb kind of a thing. So I'm not sure. Maybe some the others can also input what they think. So if you look at the top robotic surgery statistics currently, we are general surgeons. I expect we are doing inguinal hernia repair, reflux, ventral hernia, colectomy, and cholecystectomy. You see, so only inguinal hernia is more than prostates. Okay, so that's why I said there is a robotic revolution. Earlier, it was MIS meant laparoscopy, but now MIS also means robotic. Okay, will it cause to the demise of laparoscopy? Time will tell. I don't know. Now, earlier I said, how do you consider robot present or future? Because it's been around since 2010. A lot of people are using it. This statement says that over 6 billion people worldwide do not have access to robotic surgery. Okay, because most of it is in US, Europe, Japan, India, and even in India, I am very sure it is not accessible to many people. You see what Prof. Udwadia said, it should be accessible to all, no matter how rich or how poor. So if you look at that justification and this statement, it means that robotic surgery is something for the future. It's not present yet. It's only being practiced in pockets of the world. Okay, that is the unfortunate situation. What are the challenges in Asia in terms of developing robotic surgery? Okay, this limited access to advanced technology. Yeah? The ivory tower attitude means those in a bigger hospital, because it's unfortunate, it's not scalable. You can't carry your robot anywhere. Laparoscopy system you can carry to different hospitals. So this wall has to be broken down. Robots have to become cheaper, affordable, and part of the healthcare system. I think the NHS is going in that way. So hopefully the rest of the world will follow. Cost is a big issue. Setting up a robot is costly, especially if you're going for the Da Vinci. The others are not so cheap. They are maybe about 30% cheaper than the Da Vinci. The Hugo Ras is almost same price as the Da Vinci. So cost is a big issue. And not only cost, the cost of maintenance. And the biggest money maker for the robotic company is not only the initial installation, it is also the consumables you are using. It's very expensive and they make a lot of money. And it's all very personalized, company-based instrument. They have their own diathermy, monopolar, bipolar, harmonic, staplers. They make money from all, you know. So it's a huge endeavor. Okay, so that's the challenge in Asia. You can't this is unfortunately the biggest challenge. And disparity and lack of surgeons training and skill development, yes. So not all are trained. Hopefully with a society like ASI in India, then you have IAGS, RIS and all that. All this will change with more and more training being organized, more and more surgeons will do, and hopefully you can balance it. Okay. So for resistance to change, okay, this is a big issue. You have all the money, but you don't want to change. A lot of surgeons, maybe some are limited by age. Some have lost their ambition. They're not keen to take on new things. They're happy where they are, so they continue to do whatever they have been doing. Okay, some surgeons, especially the newer ones, they have been trained to have this work-life balance. So they find robotic surgery takes too much time. By the time you doc, I have finished the surgery and I'm gone home to play with my cat or dog, go for sports or go to the club. Okay, so resistance to change. And in my experience also, initially when I was trying to promote robotic surgery to patients, they were afraid. They thought, have you seen this movie called Terminator? Arnold Schwarzenegger, came from the future. So he thought the robot is operating the patient. So they said, no, 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 I want you to operate on me. I don't want robot. So surgeons get afraid. So I have to tell them, no, this is not the case. It's the robot assisted surgery. We are not autonomous, at least not yet. Okay, I'm saying not yet. Then you have to overcome learning curve challenges. Okay, so and then after all that, you have to break down regulatory and bureaucratic barriers. Some countries refuse to allow you to do because based on outdated systematic reviews. So more and more studies have to come out showing safety, efficacy, you know, uh, for this to move forward. Now, cultural and linguistic barriers also will come in any part of Asia. There are too many countries, too many cultural backgrounds, too many linguistic barriers. I have been to Central Asia to do workshops, and you find that there are no laparoscopic companies there. They are all sold by agents. So imagine the agent brings and sells at very escalated prices. Okay. Then the other reasons are limited focus on patient awareness, economic disparities, this I mentioned, and a very fragmented healthcare system. So the cost of the robot is already expensive, and because the healthcare system is dubious, it affects the cost become more expensive. Okay, so when my hospital got me a robot 2 years ago, after many years of asking and threatening to leave, I also had a doubt. Can I progress on? Because I was supposed to get it before COVID. Then COVID came, so I couldn't get. Then I got one 2 years ago. And I said, okay, let me do this like how I did my laparoscopic surgery in 2003. It has been a journey. I started off with hernias, went to colorectal, then went to upper GI, bariatric, and then ended up with endocrine, thyroids, and all those things. So I thought I will go in that same curve. But I wanted some data to show that I'm doing the right thing, not just doing for the sake of doing and then harming my patient. So I look at some data to suggest that it is safe for me to do. Then I saw a lot of good studies, to show the benefits of robotic surgery and that especially for colorectal, you can learn the skills with a short learning curve and the skills are transferable. So that is very important for me because I consider myself an experienced laparoscopic surgeon. So could I, uh, translate my experience into a robotic platform? And a few of senior surgeons who are already doing robotic surgery said, I don't worry, the downtime for a surgeon like you will be very low. The skills are transferable. So with that in mind, I didn't hang around doing hernia for a long time. I just did a few cases, then started doing whatever I was doing by laparoscopic surgery. I started doing by robotic if the patient could afford to pay. So that is robotic surgery. So you have to decide. To me, it is a glimpse into the future. It is probably here for some, but not everybody. A large majority of surgeons, this is still a future. Okay. A few of us are lucky enough to have it the here and the now. And so we may call it as the present, but it is very much the future of surgery. Definitely so. Looking at the money involved, this will move on. Now, AI, my last few slides, AI in healthcare. Now, this is not my area of expertise at all. I had to do a lot of research. And the Harvard Medical School is offering 8 weeks online tutorial on AI in healthcare. I am not sure I can do that in 5 minutes here. Okay, but based on my research, and having seen some of AI being used in day to day, this is my impression. Okay, it is very good for training, especially training modules for medical students, trainees in surgery. It's no more the era of see one, do one, and cut one. Sorry, see one, do one, and teach one. Okay, that era is gone. Mentor, mentee also is slowly dying off, because a lot of the very senior teachers and educators have left the service or retired, gone into non-academic pursuits. A lot of corporate hospitals coming up. So the emphasis now is going into more of work-life balance and more comfortable lifestyle. Okay, so this is a method of learning, and I feel it's very good when you can integrate AI into a training module. If you look at the Da Vinci, it comes with a simulator. If you put AI inside, it gives you scores. So the better you do, the better your score. So that allows you to know how bad you are and how much your improvement is. Okay, so it gives objective analysis of your skills using the AI as analytics. All this is available already. And it can be used to improve surgical curriculum. Okay, and in the publishing domain also, gone are the days where painstakingly you do system, the searching all the engines one by one. The AI will do that. The key questions will come up in minutes. Then you can do PubMed search, Cochrane database, and all that. You can search and get the AI to compile them for you. Okay, so much so when some of the studies are being published, they also have to mention, for the sake of clarity, that it was help of AI. Okay, and in surgery, yes, it is probably coming. Okay, AI enhanced image processing analysis. It will be good when you're operating, say, doing anterior resection. If the AI can identify the vessels for you, the abnormalities, the ureter, it can find for you. If you're doing hepatobiliary, it can help you to find the cystic duct. A bit like surgery made easier is important and better for difficult cases. Okay, and this is where augmentation, virtual reality augmentation with the images. You can put in CT images into the operating area to look at tumor, lymph nodes, pulmonary nodules, liver, pancreatic tumor masses and all. Okay, so this is where the next generation probably will come, or already there, where AI being applied into minimally invasive surgery. Okay, so you can do more advanced work safely, okay, without compromising on oncological outcome. Okay, and all this will help to improve patient outcome. So that's the most important thing. Okay. So some of the application, endoscopic surgeons are also into robotic endoscopy with AI nowadays. It's being spearheaded by Philip Chu in Chinese University, Hong Kong. He has published papers on this. Okay. So look at some systematic review on the use of artificial intelligence. So all that benefit, is it seen? Okay, so this is a paper, systematic review published in 2021. And they realized that the reviewed studies were of low quality, okay, and no proof that AI can identify the critical tasks of robotic assisted surgeries which determine patient outcome. So you need a larger studies with larger data sets, okay, to really see whether AI really helps or not. This is 2021, so we probably have to wait for an update on this to see. But on paper, we see so many benefits. Whether the benefits are seen in real life scenario, we don't know. Okay. So in endoscopy, it is established. So there are some systems which can identify polyps for you. Okay. And when there is an AI advising you about the presence of a polyp, the detection rate is much improved. So results in significant increase in detection of colorectal neoplasia. So this is the study in 2026 published. Okay, AR is similar, somewhat similar. What they do is they layer digital images into a surgical background to advise you. So the AI. So in the future, what I'm hoping to get is artificial intelligence or AR, which will tell me, okay, I'm preparing a patient for complex hernia. I key in the CT scan and the details and all that. Then the AI will tell me, okay, what based on the current international guideline, what will be the best approach for this patient? So this will be of good benefit, for complex cases. For simple cases, I think if you start using this, then it will cause a decay in our brain function, so we can't make decisions. Okay, so especially in neurological surgery, it helps in navigation. Okay, so a lot of studies showing navigation surgery. So that was my talk. I said 40 minutes. So my take-home message, as we reflect on the past, we appreciate the pioneers who challenged convention. In the present, we continue to refine and improve what we do every day. As we look into the future with robotics, AI, and beyond, we must remember technology will change and we with it. But principles should not. Safe surgery, good judgment, and putting the patient first will be our foundation. So with that, I conclude my talk. And this is a conference we are holding in Kuala Lumpur. It is the ISU CRS, which is a World Colorectal Conference, together with the SELSMAR Congress. It's scheduled to be held in KL, Kuala Lumpur, 23rd to 25th July. And I give you my warm invitation. If anybody is keen to present or publish, especially the trainees, you can reach out. Thank you very much.
Thank you so much. Thank you so much, Dr. Vimal, for that wonderful presentation. It was so nice. You started off with the history of surgery, history of laparoscopic surgery, and then you came all the way up to artificial intelligence in surgery. So that's a huge spectrum of topics to cover in just 30, 40 minutes. And I think you did a fantastic job. Well, yeah, absolutely. You did a fantastic job. A lot of things that we have learned. While people are typing their questions in the chat box, I just want to ask you a question. You're probably the best person to answer this question because you're from Malaysia and you travel a lot, Central Asia, Southeast Asia, and you just told me that you have returned from China this morning.
Yeah.
It's a two-part question. Why do you think robotic surgery has moved faster in the East than in the West? And the second part of my question is, when you travel to places like China, what are the things that you see different? What are the things that you see different there that you don't see perhaps in a country like India or Malaysia? Because not many of us wouldn't have traveled to that part of the world. But I'm sure they're doing phenomenal work. So what are the things that you see different in that part of the world that we don't get to see?
Okay, so to give you an example, about 6 months ago, I attended the Korean Society for Robotic Surgery. They are called KAROS. So they invited me to give a talk. So I went there and I noticed very young surgeons, they have bypassed the era of laparoscopic surgery altogether. They have gone straight to robotic surgery. Okay, so this is where they are at. They are very comfortable doing Whipples. I spoke to a hepatobiliary surgeon. Did you do open laparoscopy robotics? And or laparoscopy too hard, robotics so much easier. You see, so we are seeing that. So in China, I went for a hernia conference. They had an online thing as well, the hernia essential program. Attendance was 12,000. So 12,000 young surgeons attending to listen. Of course, language is an issue. You have to translate to Mandarin, and you have a translation device and all that. But in terms of laparoscopic surgery being replaced by robotic, this is already happening. If you talk to South American, European surgeons, we tell them our biggest problem was cost. I went for a talk, met a surgeon from Australia. She told me the first robot was in the private sector in Australia, and the cost was expensive. But after that, when there were competition, the patients have to pay a premium more than laparoscopic surgery. That cost was absorbed by the hospital after a few years. So it means the cost of robotic surgery became equal to laparoscopic surgery. So if that happens, would you ever do laparoscopic surgery? It will die. It's just the cost of buying. So the hospitals see the benefit of getting a robot. So I suspect in Asia, technology tends to work very, very well. People will dump a lot of technology into the market. We are quick to embrace it. So this is where our rationality in assessing is important. So that's why I think that in the future, more and more people will be converted. Now, you say all the clinical papers say there is not greater benefit, correct? You agree with me?
Well, some operations.
As a surgeon, if you are doing robotic surgery, will you want to go back voluntarily to laparoscopic surgery? I don't think so, because I try to do that. And when I do laparoscopy, I find myself telling my assistant, why are you standing so far away? Go nearer, go nearer. When you're doing
That's because you're
robotic,
used to
you're
that.
going so near and you're operating, So we see the difference. I think the biggest influence is, like you said, major companies coming in, and so many hundreds coming in. Okay, the downside to that is, I believe in 10 years from now, many of these companies will go bankrupt because the pie is only limited. So we have to be careful who we buy from. So China is in a spiral of technological advancement. They keep getting better and better. They have gone into robotics. So I think if you look at the Western side, South Asia, India has to be the leader in this area. China is in the world of their own. There is a national fervor to push everybody into this field. So it is very much country generated.
Thank you very much. Sir, Dr. Prasanna Kumar Reddy, sir, would you like to make any comments? You're probably the person who knows more on minimal access surgery than anybody else on this platform. So you please, we would like to hear from you. You're muted, sir. You need to unmute yourself.
Thank you very much, Jameel.
Yeah, please go.
That is a wonderful talk by Dr. Vimal, and very nicely is concluded, starting from the past to future and what is going to happen in the next. But the last words, what he said, most papers said there is not much of benefit between laparoscopy and robotic surgery. But I think I would like to slightly differ there. Some operations are definitely there is no point in doing with robot alone, with robot. Some of the major procedures, robot works very well, and the surgeons are very comfortable, and the results are also good. And no doubt about it, it is going to be expensive. And as Dr. Vimal said, hundreds of companies are coming. So the cost of this machinery will become less and less. So with the result, I think the affordability becomes better. And slowly, I think insurance companies have no choice. They have to accept it ultimately, actually, even though they are not at present. So overall, it's a nice, very briefly, and Dr. Vimal has concised the whole thing in a 40-minute talk. Thank you very much, Dr. Vimal.
Yeah. Thank you. I'm sorry, I'm having a bit of a problem with my internet connection, so I'm having to turn my video off. Today we have the pleasure of the president of Association of Laparoscopic and Robotic Surgeons of Great Britain and Ireland, Mr. Selvasekar, also log in. So he's listened to your entire lecture, Dr. Vimal. I want Selva to say a few words. Please, Selva, can you unmute yourself? Would you like to say a few words?
Yeah, thank you. Thanks very much. I know I enjoyed the presentation. That was very good, great overview of what has happened in the past and where things are going. My sort of comment, Vimal, is it is all to do with the economy. The economy is doing well in Southeast Asia, so there's a lot of robots coming in. How do we make sure that like continents like Africa, South America, where there are, how do we make sure that everyone has got access to the robot? People talk about democratizing, minimal access surgery. How do you think it is feasible?
At the end of the day, one is cost. So somebody has to make the effort to bring down the cost. Whether it happens or not, maybe by numbers, like what Dr. P.K. Reddy said, when more and more companies come in, especially the China-based companies, and they have built a Silk Road to Africa now, correct? Many of the African nations, they are dependent on China. So they have access to that. They have built the robots. So it won't take long for them to bring it there, So that's one thing. And they will also provide training. Just like Da Vinci provided us intuitive with training and proctorship and all those things. So they will find a way because for now they are satisfied with the Chinese market. So if India were to take a lead in this, that will be another market. So we have to look out for each other because the next generation, everything is going to be in Asia. Asia is going to be the viewpoint. Everybody will look to us. So major countries have a big role to play.
Thank you. Thanks very much. Thank you.
Thank
Excellent
you.
talk.
Dr. Kannan, would you like to pass any comments?
Thank you, sir. Thank you, Dr. Vimal, sir, for the wonderful lecture. You have given an overview about the past, present, as well as the future of the minimal access surgery, especially AI integrated robotic assisted surgery. Yeah, in fact, whoever watch here, enjoy your talk. In your version, what is the difference between handling the Da Vinci and comparing with other instruments? Because people are telling that the Da Vinci is very easy while using this. When comparing with either Medtronic or other companies, the new Chinese coming instruments are coming up. So what do you feel? What is your experience?
So there are some like the Da Vinci is like one system with multiple arms. Some they come with individual arms. So that is one thing. So the thing about robotic surgery, if you have that system with multiple arms, how you put your trocars are very important. How far away from the tissue where you're operating is important. If you can't just do it like laparoscopy, and then you adjust it as you go on. Cannot. You'll struggle. So you have to think a lot about patient positioning, demeanor of the patient, and all that. Second thing, a lot of the robots, they are not in. You see, Da Vinci is already the 4th or 5th generation. Whereas the other companies are in the 1st generation, So they have a 20 years head start. So no matter how good or how updated they are, they will have some, especially lag period. So when you are doing something, there is some lag. So this is often disturbing. You have to get used to the lag. So these are the two things I have noticed about all the various companies. Third thing is if you buy from a company which you are unsure of just because of the initial cost, if they don't have the proper instruments for you to do your procedures, you'll be in trouble. And if the long-term maintenance, if the company folds up, you are stuck with the expensive toy, which you can't use.
Yes.
I agree.
Thank you,
with
sir. And Dr. Jameel,
Thank you.
Dr. Rajesh is
Yeah.
here from UK.
Yeah, sure.
What-
Rajesh,
Rajesh,
TK Rajesh
comments from your side, yeah.
from Plymouth. Rajesh, would you want to
Make any comments?
say a few words? Have you got any comments? Okay. Well,
Let me
I
unmute.
think
Unmute.
Yeah,
Yeah, I got it. Yeah, I'm here. Yeah. Nice talk, Jameel. I was
Yeah,
listening to the whole of the talk and see how we have progressed from open to laparoscopy to now do robotic. So one of the comment which I need to make here is I've been started doing robotics since 2019. Yeah. So definitely there is a benefit for patients as well as the surgeon. So we are not young surgeons now. We are getting a stage of retirement and post-retirement, but we got the skills, we got a skill set, we got everything. So, and also when we find there's a learning curve, during the learning curve, I'm unable to see any difference. But once you finish a learning curve or a developmental curve, and we have progressed more than 100 cases, every procedure, robo is better, including inguinal hernia, to umbilical hernia, any hernias or any resections or any procedure, I feel at this stage, robo is better than laparoscopy. So in future, the publications will come, research will come, and definitely it will show robo is much better. The main thing is three-dimensional view and a static platform, and you are comfort, and you are doing the surgery at comfort. So when I'm doing the surgery, I'm able to communicate with the team. I'm able to communicate with my secretary. I can do many things, which is we are unable to do with the laparoscopy. So future is AI and robotics. Thank you, but very fantastic picture, overall picture from basics to the from Karnataka to Malaysia to world. Thank you, Jameel, for a wonderful time. Thank you.
Thanks
Thank you,
to Dr.
Rajesh.
Vimal.
Jameel. Rajesh,
Yeah.
thank you. But what is
Thank
the standard? Laparoscopic surgeon become a robotic surgeon. Of course, it is individualized. But what is the standard? How many surgeries?
Standard. So standard is basically after 90 cases. So the Cleveland Clinic, this Steve Wexner published, if you are more than 90 patients you are done robotically, then you are comfort with the instrument. What I teach everyone is a tool in the hands of a fool is still a tool. So you should be a wise man. You should understand the tool better. Then you will get a comfort and you will cross over all the basic difficulties. Yeah. So after 90 cases, you are an expert and you will produce much more results in your robotic surgery. And also conversion from open to, I do not know, laparoscopy to robotic is easier because already you learned a platform on laparoscopy. Right. So laparoscopy to robotic is much more better, I would say. Directly open to robotic, it can be done, but you need to know the system. Yeah.
What do you think about the haptic feedback based on your experience of doing laparoscopy? Do you feel it?
No, after 20 cases, basically you develop a neuron. Basically, what I say is your eyes will form a extra neuron with your hands, and your perception improves. Now, yesterday I was in International Hernia Symposium in Barcelona. I was there in the BD as sponsored this particular conference, and I was able to see all the hernias, varieties of hernias done robotically, and I was able to try the Da Vinci 5. Da Vinci 5, I was able to lift the weight, and I can feel the weight in my hands. So haptic feedback is there, but after 100 cases, you don't need a haptic feedback. So your eyes will tell us, and how much you basically you would understand how much strength you are giving by your visual acuity. You improve your haptic feedback.
Thanks, Rajesh. Thank you for those.
Thank you.
Great comments.
Our past president IAGS, Satish Mehta sir, is here.
Sir, Dr. Satish Mehta sir. Is he logged in?
Not yet. He is logged in, but not yet unmute.
Okay. Maybe he is busy. Okay.
Jameel, can I just?
Yes, sir. Please go ahead.
We were talking about haptic feedback.
Yes.
We all had the same thing when we started the laparoscopic surgery.
Right.
And then after doing few cases, automatically you feel, as Dr. Rajesh has mentioned quite rightly, you will automatically get that sensation of haptic feedback after doing certain number of cases. I mean,
Yes.
exactly, there won't be much difference at all. I'm
No.
doing all these cases,
Yeah.
what I realize it.
I remember back in
Agreed,
the
sir.
day, we used to have these
Agreed.
palpation probes.
Agreed.
Yes, correct. Okay.
But after many years, we don't use palpation probes anymore. Any instrument we put inside, we can feel it.
Agreed, sir. Agreed. I can see Dr. Satish Mida, the immediate past president of IAG, is logged in. Sir, Dr. Mida, sir, would you like to say a few words? Okay. Okay, no problem. So yeah, I think very interesting discussions, lots of pertinent points. Vimal, can I make a few points?
Sure.
On the some of the slides that you have shown. The first is on haptic feedback. Sir has very nicely said given his opinion. Rajesh also alluded to it. I don't see that as a problem at all, to be honest. I know this new version of DaVinci 5. I have not seen it. I've not had a feel of it. Rajesh has had a feel of it in Barcelona. It hasn't come to India yet. I know the company says that this haptic feedback issue has been dealt with and you will have some kind of a haptic feedback in that new DaVinci version. But the current version, the XI, we don't see it as a problem at all because of the other advantages that the Robo gives us. And this is what I've mentioned in the chat box as well. You have an excellent 3D vision. You have a lot of magnification, less blood loss. You're operating close to the target organ. It's almost like you're inside the abdomen. So this lack of haptic feedback is never a problem. That is one. The second comment I want to make is on the final slide of yours, AI in robotics. I entirely agree with all the statements that you have made there. Then when AI comes in, which could be in a few years' time, if ever AI was going to get incorporated into a minimal access system, it will be a robotic system. I don't think an AI is going to get incorporated into a laparoscopic system.
I agree with you. Robotic platform will be the one to have AI and AR. What kind of surgeons will we start producing where the decision making is taken out of the surgeon's hand? Every decision. There are benefits, no doubt about it. But we will not see an era of super surgeons like Dr. P.K. Reddy, Palnivelu, and all that. We won't see that era. What will happen is we will have a larger group of surgeons. All can do a lot of advanced procedures to the same standard, but they will be very dependent. But for now, like I said, the papers don't show that the AI can give you that kind of information, which can where decisions intraoperative can be made. So there is still a role for experience, So this is where we are. Of course, it may change,
We'll have to wait and see.
Yeah. But
Yeah,
again, medico-legally, now if the AI makes a decision, so who is responsible? So that is
that's
another
a different
area.
subject altogether. Yeah, I agree.
That's why autonomous is probably not possible. Because if the robot is autonomously doing surgery, technology may be there. But who's going to put a trocar for the robot? So you become a skilled merchant, just put trocar and the robot does the surgery. Will the company bear responsibility if something goes wrong? Will the hospital take responsibility? Medical, legal, a lot of things, ethics.
Dr. Satish Mida, sir, past president of IAGS. Sir, would you like to unmute yourself?
Good evening, everybody.
Good evening, sir.
Good evening, sir.
We heard the nice lectures by Dr. Vimal and the views of everybody on how the technology has progressed. I think we have to go with it. And if we start denying it, we will miss the train. So we have to take the best out of it so that we can give best to our patients. I know there are many other angles involved, as has been shown by Dr. Vimal, that especially the financial aspects, the affordability and the availability, all these are going to be part of it. But anyway, we have to be with it, and these advancements will be used for the benefits of the patient. Thank you very much.
Thank you, sir. And thank you so
sir.
much.
I
Thanks-
think
Yes,
societies
sir.
also will have a
Um,
big role to play.
Yeah.
Yeah, good evening,
Societies.
Dr. Vimal.
Dr.
Yeah.
Saravanan, please go ahead.
This is Dr. Saravanan from Chennai. As you said, this is not the end. Robotic is not the end of our profession. There is some more future. So, is there any AI-aided surgeon-less surgeries? Like, no, once you dock the instruments, the robot itself will do. As Jameel was telling all the other day, whether this robot is doing surgery or surgeon is doing surgery, people are asking. So in that way, is there any possibility of bringing a machine which can do surgery in the future?
If you listen to Elon Musk, he says the technology is already there.
Yeah.
You know?
Right now, I'm
So,
sitting in my Tesla, so
But
driverless.
the question is there a need? You know, everybody thinks the surgeons will die off and robots will do, but somebody has to dock the robot. The robot cannot dock itself.
Yeah.
So who's going to be, which surgeon is going to do that for a robot, which will take away his expertise and skill? So
There may be.
this is where surgeons have to be together. Societies will come into play. You know, governments will come into play. So these are the greater issue. Of course, in the area of anesthesia, they have robots which can do intubation now.
Yeah.
You know,
So
so
it's
high
like,
skill set. But is it good if every patient is intubated by the robot? You know, and similarly, other areas we don't talk about others. So only for surgery, the technology is available, but at the moment it is semi-autonomous.
We'll have to wait and
Yeah.
see. Wait and
it's
see.
like physician assistant.
Hopefully not in our working career.
Well, you never know, Vimal. We never know.
We
The
don't
way
know.
things are progressing. You
All
never
this
know what's
happening
going to happen
from
in
the
5 years'
90s
time.
onwards.
So these are unpredictable.
I was listening to one very popular robotic surgeon from Italy, and he was saying something like along the lines of, if you can get a motor car, to navigate through the streets of San Francisco without a driver, I don't see any reason why you can't get 3 instruments, take a gallbladder out of somebody's body.
Exactly.
Try doing that
Well,
in
it may be an exaggeration. I don't know.
Correct,
It's a world-renowned robotic surgeon saying this.
And
Yeah.
in fact, actually, what Dr. Saravanan mentioned, if you think of the things, how they are progressing, the putting the ports and all may not be difficult in course of time. The humanoid robots, they will be able to put these ports. And as far as the inside, the procedure is concerned, all the steps are standardized.
Yes.
So all the steps will be fed into the robot, and the robot will do the job. And so actually, it may become true, but at present, what I feel, the surgeon has to be there. Surgeon's involvement will be there, as far as I can see. Because you're all young people, that may be different, but as far as I can see, surgeon's involvement will be there.
In this context, I would like to tell everyone that there must be a good open surgeon to become a robotic surgeon or super robotic surgeon. So everyone, even the younger generation should know how to do the open surgeries also. So then only they can become a good robotic or laparoscopic surgeon. So everything is important in the future. Thank you.
Great.
If you look at learning curve for new surgeons, it is shorter for robotic surgery as when compared to laparoscopic surgery. So it takes longer for them to learn laparoscopic surgery than to learn robotic surgery. So in the future, when that becomes a reality, a lot of them will choose robotic surgery. I think this is what has happened to the urologists. They've started doing robotic prostatectomies.
There is no open prostatectomy nowadays. No, everything by. Yeah.
I knew back then there were some surgeons in India doing laparoscopic prostatectomies.
No.
Now there isn't any. Now it's almost entirely robotic. I mean, it's open or robotic.
It should be
there's no laparoscopy.
Yeah.
No. Okay, so I think.
Any other comments? Some of our friends are there. Johnson, some Chandru. Any comments from any of the participants? Okay.
Okay, so so I think we've had a good hour and a half, 1 hour, 40 minutes of discussions. Great presentation followed by very interesting and lively discussions. So we'll bring the program to a close. Please go ahead.
Good evening, Dr. Vimal, Vasudevan, and the seniors and all our ASI Chennai chapter. It was a great lecture. Everyone, in fact, I was listening throughout the lecture. It was very useful. And I thank Dr. Vimal Vasudevan profusely for presenting this topic. And this is the need of the hour. So everyone should know what is happening, what has happened, how it has gone through. And I thank our senior Sir Dr. P.K. Reddy and Dr. Satish Mida and all the seniors. And I'm really happy that people have joined from all over the globe, like Dr. Rajesh from UK and all that. I thank everyone who has joined and actively participated in the discussion. Thank you very much. Thank you.